Namaskar. Hi friends, welcome on our channel. This video is intended for healthcare professional and postgraduate students to explain basics of bone and soft tissue tumors, how to evaluate them and its radiology. It's not a guideline or it doesn't carry any medico-legal implications. When you hear a word orthopedic oncology, what strikes your mind first? The answer is tumor prosthesis or mega prosthesis. But orthopedic oncology is more than just a mega prosthesis. We deal with small tumors in hand like GCT of tendon sheath which measures in millimeters to monstrous tumors and complex surgeries involving pelvis like internal hemipelvectomy. We are constantly looking to strike the right balance between the disease clearance and tissue preservation for better functional outcome. As in this case of Ewing sarcoma of pelvis, conventionally patient would require type 1 internal hemipelvectomy, which will lead to discontinuity between acetabulum and sacrum and limb length discrepancy. But with aid of 3D printed patient specific instrumentation, we could salvage a bridge of bone between sacrum and acetabulum after taking adequate oncological margin, and we could prevent limb shortening, and as a result of that patient was walking on post-op day 12 without any support. Now let's start with evaluation. This flowchart explains how to evaluate bone and soft tissue lesions in orthopedic oncology. For a soft tissue lesion, evaluation doesn't change with age, whereas bone lesions are evaluated differently in elderly age group. All patients are primarily investigated with local radiograph. For patients with soft tissue lesions and those with bony lesion with age less than 40 years, local imaging is done, which is contrast MRI, followed by needle biopsy, followed by staging based on histology of the tumor. For tumors, contrast MRI is choice of investigation instead of CT scan, which is routinely prescribed in trauma practice. Reason being, MRI gives more detail about soft tissue and marrow involvement as compared to a CT scan. If we compare CT and MRI images of the same patient at the same level, demarcation between disease and normal tissue, relation of tumor with respect to surrounding muscle, vessels and nerves are better seen on an MRI. Heterogeneity within the tumor is better identified on MRI. This helps in avoiding cystic and necrotic area and target the right tissue for the biopsy. Most importantly, extent of marrow involvement is precisely demarcated on an MRI, and skip lesions are easily identified on coronal T1 sequences. So, MRI is the investigation of choice for musculoskeletal lesions. FNSE is never done for diagnosis of sarcoma. It yields only cytological information, but no details about matrix, which is crucial for correct diagnosis in sarcoma. And there is no role of excision biopsy in bone tumor because by definition excision biopsy can be done for tumors which are less than 3 cm, those which are superficial to deep fascia and away from the vital structure. No bone lies too superficial to the deep fascia, and bone is a vital structure by definition. Hence, excision biopsy of bone tumor is not possible and must not be done. Core needle biopsy is adequate, and it is proven in multiple case series and meta-analysis comprising thousands of patients. Open biopsy is not advised because apart from the fact that it gives rise to more contamination during biopsy, in sarcomas we need to excise the biopsy tract during final procedure. So, in open biopsies, more tissue is resected along with the tumor compared to the core needle biopsy. Open biopsies are only done if 2 needle biopsies have failed or if the pathologist needs more tissue for ancillary studies like molecular analysis. Biopsy sample should be sent to an experienced pathologist who routinely reports bone tumors. Patients who are older than 40 years presenting with bone lesion, the cause is likely to be metastasis from somewhere else or secondary to multiple myeloma. So in this scenario, we need to first identify the primary. Patients should be asked for history of swelling at any other site, bleeding from natural orifices or any surgery like hysterectomy, which may point towards the primary. Sometimes respiratory, breast or per rectal examination may also help in identifying the primary. If history and examination doesn't help, next is MET myeloma workup, which comprises blood investigation including tumor markers such as PSA for prostate malignancy, CA-125 for ovarian tumors, CA-19.9 for pancreaticobiliary malignancies, and CEA for colorectal malignancies. Serum immunoelectrophoresis with immunofixation, free kappa and lambda chains, urine for Benz-Jones protein, and skeletal survey will help diagnosing multiple myeloma. If all these investigations fail to identify the primary malignancy, FDG PET scan from head to toe is the investigation of choice. PET CT also gives an idea about the disease burden and helps us to identify a more accessible site for subsequent biopsy. If PET scan is not available, then contrast enhanced CT scan of thorax, abdomen, pelvis and USG neck can also be done to identify the primary. Although skipping tumor markers and getting FDG PET CT or CCT is more affordable option in cost constrained setting. In more than 90% of the cases, primary will be revealed. In 10% of the cases, a primary could not be found on PET CT scan also. But when we are still not sure about the origin and FDG PET CT reveals only a single bony lesion, local imaging in form of MRI followed by biopsy is performed. Now, how we should prescribe radiological investigations for evaluation of musculoskeletal lesions. X-ray should always be full length, covering one joint above and one joint below. MRI should always involve full length of affected bone to rule out skip lesions, and preferably with contrast, especially when evaluating cystic lesions or when we are suspecting infection. PET scan is mostly done only till mid-thigh. So for musculoskeletal lesion, it is prescribed to include from head to toe. When CT thorax is done to look for lung metastasis, non-contrast scan with thin slice lesser than 3 mm is advised. Now, through an example, we will try and learn why following this flowchart is very important. This was an elderly female presented with fractured femur who ideally required investigation to identify the primary tumor. But patient wanted pain relief before any further investigation, so interlocking nailing was done. Also, most of the orthopedic surgeons feel that a fracture has to be fixed, so why to delay? So as many times happens, the pathological fracture was not evaluated properly in this case also, and later patient presented with second fracture. An important lesson from this case is that pathological fracture is not an emergency. So please splint and evaluate properly before any definitive surgery. Otherwise, it may endanger patient's limb or life. This was a young male presented with pathological fracture of femur. MRI was done and reported as fibrous dysplasia. So treating surgeon nailed it, but later it turned out to be Ewing sarcoma, and patient who deserved a procedure like proximal femur replacement eventually ended up in total femur replacement followed by radiotherapy due to the contamination. This is another common mistake that most of our colleagues make, that they assume that the radiological diagnosis is the final diagnosis and don't ask for a biopsy before proceeding with management. But still, these patients were lucky compared to this young male who presented with hip pain. Radiograph and MRI were reported as giant cell tumor of bone. So excision biopsy and bipolar processes with iliac crest bone grafting was done. Later on, he presented with this huge lesion and it turned out to be osteosarcoma. Only option left was hindquarter amputation to clear the disease. A patient who could have been managed by proximal femur replacement ended up with quite disabling hindquarter amputation. This could have been avoided by proper evaluation via following the flow chart. Diagnosis in orthopedic oncology is a coherent picture produced by clinical, radiological and pathological information. If one part doesn't fit with another, diagnosis should be revisited. To understand, we will go through another case scenario. A 20-year-old male presented with left hip pain. Outside biopsy was reported as chondroblastic osteosarcoma. But osteosarcoma doesn't occur in epiphysis, so radiology and pathology was not fitting with each other. Hence, We decided to repeat the biopsy at our center, which was also reported as chondroblastic osteosarcoma. To emphasize, this was reported at a center where pathologists routinely report biopsies of bone tumors and they were quite confident about what they were seeing. We were in dilemma again. At that time, history came to the rescue. Patient said that he had pain for 1.5 years, which decreased in between, which was more in favor of a benign bone tumor. Meanwhile, patient MRI was already 2 months old. So we repeated MRI and documented very little progression, which was again going against sarcoma. We made some literature search and realized that sometimes chondroblastoma on histology mimics chondroblastic osteosarcoma, especially in previously intervened cases, which was biopsy in our case. Case was discussed in multidisciplinary team and a plan for curettage was finalized instead of resection. 4 years down the line, patient is disease free, which again proves that it was a chondroblastoma to begin with and not a sarcoma. One should follow this flowchart and make sure that clinical, radiological and pathological information are coherent with each other while reaching to the diagnosis in orthopedic oncology. Now let's move on to X-ray reading. For bone tumor, X-ray is the diagnostic imaging and MRI is an anatomical imaging. It is an X-ray which gives you the diagnosis and MRI will substantiate the diagnosis. The non-overlapping information provided by each of them helps us to arrive at a correct diagnosis and plan the surgery. We will understand how to read a radiograph in a systematic manner, which will help us in exam as well. We will take this radiograph for our discussion. We will divide the radiograph reading into 3 parts. First part describes the radiograph itself. 1. Type, whether radiograph is plain or with contrast. 2. Which bone and joint it is showing. 3. Whether it's a mature or immature skeleton. And 4. Plane of radiograph, meaning AP or lateral view or some specific view. So first part of radiograph reading for this radiograph will be, this is a plain radiograph showing left knee with distal femur of an immature skeleton in both AP and lateral plane. Second part of radiograph reading describes the lesion. This part will be again divided into the 3 segments. First, location. Lesion can be in the epiphysis, metaphysis or diaphysis or combination of the above. Second, what tumor is doing to the bone. So what tumor can do to the bone? First, it will produce some kind of matrix, either fibrous, which will look lytic on radiograph, or osteoblastic or chondroblastic or mixed. Second, it will do something to the cortex. Either it will scallop the cortex or it may expand the cortex or it may permeate the cortex. And third, it may or may not produce some kind of soft tissue component. Third is what bone is doing to the tumor. Whenever there is any specific activity in the bone, normal bone will try to contain the lesion, which will lead to zone of transition. Depending on the aggressiveness of the lesion, the zone of transition may be wide in case of malignant lesion and narrow in case of benign lesion. This can be explained in a way that in case of benign bone tumors, rate of tumor growth is slow. So, bone is able to efficiently restrict tumor growth, which sharply demarcates zone of transition. On radiograph, one can draw a line on one side of which will be tumor and on the other side of it will be a normal bone. Whereas in malignant tumors, the zone of transition will be diffuse or wide as the rate of bone destruction exceeds the healing response of the bone. Another response that bone can show is throwing a periosteal reaction. It can be solid in case of benign bone tumors, laminated in case of infection or sarcomas, or sunburst appearance in case of osteosarcoma. Another type of periosteal reaction can be Codman triangle, which occurs due to acute elevation of the periosteum, which is a hallmark of an aggressive lesion, mostly seen in malignancy like osteosarcoma, but It can also be seen in aggressive benign bone tumors such as aneurysmal bone cyst. To summarize, second part of radiograph reading for this radiograph is there is a lesion in metaphysiodiaphyseal region showing lytic and osteoblastic matrix. There is a permeation of cortex and soft tissue component. Zone of transition is wide and there is a sunburst type of periosteal reaction and Codman triangle is seen. Third and last part of radiograph reading is overall status of adjoining joint and bone, like presence of arthritis or pathological fracture. Adjoining joint, which is a knee joint in our radiograph, is normal and there is no pathological fracture. To repeat a complete reading of this radiograph, this is a plain radiograph showing left side knee with distal femur of mature skeleton in both AP and lateral planes. There is a lesion in metaphysiodiaphyseal region showing lytic and osteoblastic matrix with permeation of cortex and soft tissue component. Zone of transition is wide. There is a sunburst type of periosteal reaction and Codman's triangle is seen. The knee joint looks normal and there is no pathological fracture. Now we will see that how some of these points can help us to differentiate between benign and malignant tumors. First, cortex. Malignant tumors will permeate the cortex, whereas in benign bone tumors, they will either do scalloping of the cortex or it will expand the cortex. Second, soft tissue component. Most of the benign bone tumors except giant cell tumor of bone do not produce soft tissue component, whereas most of the malignant tumors will produce some soft tissue component. Third and most important is zone of transition. Wide zone of transition is a hallmark of malignancy. If zone of transition is narrow and there is a sclerotic line around the tumor, it means that tumor is giving some time to the bone, which implies that tumor biology is less aggressive. Fourth type of periosteal reaction. Solid type of periosteal reaction is produced in cases of benign bone tumors. Laminated type of periosteal reaction is usually seen in infection and Ewing sarcoma. Sunburst and hair on end kind of periosteal reaction signifies that tumor cells are permeating through the Harvesian canals, which means that tumor is malignant. Codman triangle is produced when there is an acute elevation of the periosteum, which is possible only in malignant tumors. Exception to this is aggressive benign bone tumors such as aneurysmal bone cyst. Now we will discuss bone tumors based on common radiological characteristics. Based on location, tumor occurring in the epiphysis are chondroblastomas, giant cell tumor of bone, Brodie's abscess and geodes. Metaphysis is the most common site for bone tumors. Bone tumors that occur at this site are osteosarcoma, chondrosarcoma, aneurysmal bone cyst, metastasis and lymphoma. Tumors occurring in the diaphysis are Ewing sarcoma, fibrous dysplasia, Langerhans cell histiocytosis and osteoblastoma. However, this doesn't mean that osteosarcoma cannot occur in the diaphysis and Ewing sarcoma doesn't occur in the metaphysis. Bone tumors can occur at any location, but specific bone tumor has predilection for specific location. Now, based on matrix, osteoid matrix is produced by osteosarcoma and osteoblastoma. Chondroid matrix is produced by enchondroma, periosteal chondroma and chondrosarcomas. They can produce either stipple type of calcification or cotton wool type of calcification. Fibrous matrix, which looks lytic on radiograph, is produced by giant cell tumor of bone, fibrous dysplasia, Ewing sarcoma, myeloma and metastasis from thyroid or renal cell carcinoma. Based on cortex characteristics, expansion of the cortex will be there in case of giant cell tumor of bone and aneurysmal bone cyst. Scalloping of cortex will be present in enchondroma and low-grade chondrosarcoma. Permeation of cortex will be there in osteosarcoma and Ewing sarcoma. Soft tissue component will be present in all kind of sarcomas and in giant cell tumor of bone. Zone of transition and periosteal reactions are already discussed. Next few slides we will do some radiograph reading with depiction of what we have discussed so far. We will discuss radiographic features of common benign bone tumors. First, giant cell tumor of bone. It is an epiphyseal tumor, eccentric in location, produces lytic matrix It may expand the cortex and it may have a soft tissue component. Zone of transition will be narrow and there will be no periosteal reaction until bone has fractured. It has a peculiar soap bubble appearance on radiograph. Second, aneurysmal bone cyst. It occurs in metaphysis, eccentric in location with lytic matrix and expansion of cortex. It may rarely have a soft tissue component. It has a narrow zone of transition. It can have a Codman triangle kind of periosteal reaction. It has a peculiar fluid level on MRI. Unicameral or simple bone cyst. It usually occurs in diaphysis, centric in location, without any matrix production or expansion of the cortex in most of the cases. It never has soft tissue component. Zone of transition is narrow and it does not produce any kind of periosteal reaction. On MRI, it has homogeneous fluid appearance which does not enhance with contrast. Thank you. In subsequent videos, we will cover common topics of orthopedic oncology which are also asked in theory exams and has implications in day-to-day orthopedic practice.